All right, good afternoon, everybody. Welcome to the Allina Health Weekly COVID-19 update. With me again today, I have Dr. Rachel Lanasa, Dr. Dan Anderson, and Dr. Steve Bradley to both present and to answer questions live. Just a reminder that you can receive CME credit for this if you put in your A or D number and then put CME in the chat questions, and then you'll receive an email later on next week with the certificate. And then there will be a posting of this webinar that will go to the AKN Provider Resources page with a YouTube link as well later this afternoon. And just a reminder to include your if you don't have an Allina email, to put in your non-Allina email. All right, so with that, we'll get started and I'll hand it over to Dr. Lanasa.
All right, good afternoon, everybody. So here we go. All right, so for the update today, what we'll talk about is current epidemiology. I'm going to give a little bit of a literature update. This is going to be a little bit different structure than what I've done before. We'll talk a little bit about treatments and testing, and then kind of just talk about some Allina-wide updates today. So we'll kind of go over the epidemiology within the United States. As you can see, where there's still current hotspots, specifically in the South and on the East Coast. In the United States, we have about 460,000 cases and 16,000 deaths. In New York City, I believe they have about 150,000 cases, which is more than any other country in the world, and their deaths, I think, make up about 44% of our deaths in the country. So I think they're at around 7,000 deaths. So really being hit hard in New York currently. In Minnesota, so good news is we seem to be flattening the curve a little bit. As I'm sure everybody saw, Governor Walz extended the stay-at-home order to bring us through May 4th. And we have about 1,200 cases in Minnesota. That when you take that over the total test, that gives us about around 4% positivity rate, and we have about 50 deaths. There have been about 293 cases that have required hospitalization in the state. Carolina, as of this morning, we have identified 169 cases, and for our inpatient positive, so currently there are 20 non-ICU positive patients with 14 patients in the ICU. So I mean that is a little concerning, just kind of demonstrating how many of these patients actually do require ICU care. And then as far as our PUIs, we have 60 patients not in the ICU, and then 7 are in the ICU. So I wanted to kind of go through a weekly literature review. I thought this is something I might try, and feel free to give feedback one way or another. But I just kind of wanted to go over a couple of the papers that are coming out every week, just because things are coming out at such kind of a breakneck speed. So I chose a couple of papers that I thought might be relevant to our practice. And so the first paper is looking at basically patients that were hospitalized in the United States as part of our COVIDnet surveillance network. So they looked at 482 patients that were hospitalized last month across 14 states, which kind of represents about 10% of the patient population, and kind of looked at the characteristics of these patients. And so, not surprisingly, most of the patients that were hospitalized were older, so greater than 65 years. That was 43% of the patients. And concerningly, 580 of these patients had racial data, and 45% of the patients who were hospitalized were white, and 33% were Black, 8.1% were Hispanic. And so it does seem that that people of color are disproportionately affected by the virus, and there is a disproportionate burden of illness, most likely, potentially related to social determinants, health inequality. And so I think that's something that we're seeing that is very concerning. So another paper that I wanted to talk about is basically an emerging infectious disease. And it is modeling that looked at kind of initial estimates in China and what we thought the reproduction number was, and then kind of some changes to modeling that was made. And there was a new reproductive number that was found. And so initially, the number was thought to be 2.2 to 2.7, which just basically means for every case that you have then, 2.7 or 2.2 to 2.7 cases from that one case. And so based on some new modeling that kind of inferred the outbreak dynamics in Wuhan and made some additional kind of assumptions and brought in some more data, is estimated that potentially the reproductive number is higher than we thought initially. So instead of the 2.2 to 2.7, the estimation is 5.7, which is much higher than what we thought. So that is also concerning. Another paper is in JAMA, looking at the characteristics and outcomes of patients who were hospitalized in Italy in the ICU. And the median age of this patient population was 63 years, so older again. And of the patients in this group, 26% died and 58% are still in the ICU. So this is kind of an ongoing study with a median ICU stay of about 9 days. And so I think this kind of, is in line with kind of some of what we're seeing here, in that a lot of these patients require very extensive ICU cares for a long period of time. And there is significant mortality of patients who are in the ICU. And then kind of tying back to what we talked about last week, there was another French study looking at the combination of hydroxychloroquine and azithromycin. And they took 11 patients who had moderate to severe COVID disease and gave them 10 days of hydroxychloroquine and then 5 days of azithromycin. And they their outcome was the same as one of the papers we had talked about last week, where they were looking at positivity of the MP swab. And if you recall, the study I mentioned last week, that there was thought to be maybe faster clearance of the virus in the patients who got these medications. And here they found that these patients, that was not the case, that these patients still had positive swabs. So once again, indicating it's probably not a great treatment regimen. So just a couple of papers that I thought were interesting. And so now we'll kind of talk about some of the treatments. Updates. So unfortunately, we are not at this point able to get remdesivir. It seems that Gilead had moved to kind of the expanded access for the antiviral, and they have a list of hospitals that they are, everybody's trying to get it. And I think that most of their supplies are probably going to hotspots. And it seems that at this point, it's not likely that we're going to be able to get access to the drug. So we did remove that from our treatment algorithm. They are, however, offering compassionate use for patients who are pregnant or children. And so if it is something that you are interested in for one of these two patient populations, contact ID, and we can work on helping you get that paperwork through the Gilead website. Another update was hydroxychloroquine, went through kind of emergency FDA approval for COVID therapy, and they did make a recommendation as far as dosing. And so we did change our initial loading dose. Instead of we were doing 400 milligrams 2 times a day for a loading dose, we moved to 800 milligrams once a day up front. And also, there we go. And then also have QTC monitoring available on our treatment website. And so basically, we're not advising hydroxychloroquine for patients who have a prolonged QTC above 500, and for patients who have, relatively long QTC, so above 470 for males or above 480 for females, we're recommending close electrolyte monitoring. And then for all patients, we're recommending a repeat EKG after their second dose, and initially an upfront EKG as well. So more guidance there. And then I just wanted to give an update on the University of Minnesota. They were initially doing a post-exposure prophylaxis trial for hydroxychloroquine. They're also, this week, they initiated a pre-exposure prophylaxis trial for hydroxychloroquine. And so they're looking for interested parties who can register online, and specifically looking at healthcare workers. So people on the front lines in the ED, ICU, EMS workers, COVID-19 units. I believe that, they are trying to target kind of some of the areas where there's limited PPE out on the East Coast, but I believe that they are also accepting people who are interested in the study within Minnesota, the Twin Cities. So if you're interested, basically feel free to send them an email and they will give you more information. And next, I kind of wanted to talk about convalescent serum as a therapy, because I think we're probably hearing more about it, and I've been getting a lot of questions. And so basically the idea for convalescent serum is you take serum from patients who have recovered from an illness and they have antibodies, and you give that serum to patients who are currently ill. And it's an old therapy. It's been used throughout the years. It was used, here's a paper from 1934. It was used to halt a measles outbreak in a prep school, so kind of an old therapy. Convalescent serum was used with success in some small groups against H1N1, SARS, and MERS, less so in Ebola, but it is definitely a therapy that is being currently investigated because we are really limited with our therapies for COVID. And so here is an article out of JAMA just a couple of weeks ago, and it was a case series of 5 patients who had COVID-19 with ARDS in China. These patients, I will note that only one of them had any comorbidities. One patient had hypertension and mitral insufficiency. Everybody else was relatively healthy, and the criteria was that these patients had to have pneumonia with rapid progression and a high viral load despite antiviral treatment. They needed to be hypoxic and on the ventilator. And these patients were given convalescent serum 10 to 22 days after admission from patients who had recovered. And the outcomes that they were looking at was change in body temperature, SOFA score, PaO2 to FiO2, viral load, serum antibody titer, and then resolution of ARDS or vent support. And so they have the characteristics of the patients here on the left. And then on the right, you can see on the days post-transfusion, you can see that their cycle threshold. So that's basically, a way to measure somebody's viral load decreased with after getting the convalescent serum. Patients' SOFA scores went down, their oxygenation improved, and their body temperature came down. I believe all of these patients did survive, and I believe a couple of them might, as of publishing of this paper, were still in the hospital. But very small case series that is limited, but shows that potentially there could be some efficacy with convalescent serum. And as far as kind of for our intents and purposes, so convalescent serum is being evaluated an investigational agent. And so Mayo has an IND that they're offering, and we are, as Allina, have filed an IRB application that is currently being evaluated. And we're hopeful that we'll be able to join on to this study within the next week or two. Dr. Rame is helping us with this, and he's kind of the go-to guy here. And so as far as who potentially might be a candidate for convalescent therapy, so it would be hospitalized patients who are 18 or older, have PCR confirmed COVID-19 with severe or life-threatening disease, and then are either able to consent or have a proxy to consent. And severe disease is basically categorized as having one or more of shortness of breath, a high respiratory rate, hypoxia, lung infiltrates that seem to be progressing. So I think a fair amount of our patients who would be hospitalized could be potentially in the severe category, and then there's a life-threatening category, where these are the patients who have respiratory failure on the vent, septic shock, or multi-organ dysfunction. And how this would potentially be obtained is it would be, I believe that Mayo is working through the Red Cross, but we would be working with our lab medicine and with and working on finding a way to be able to get us the convalescent plasma in a timely fashion after identifying these patients. And so this is kind of a work in progress. But right now, the Red Cross is accepting donations from patients who have recovered from the disease. So I think in the meantime, I would encourage us all, if we have patients who are recovered, to consider donating to the Red Cross. And so kind of they have the same blood plasma donation rules that apply as far as weight goes, and certain health conditions. And specifically for these patients to donate for plasma, they need they need required confirmation by positive PCR. So, that limits it in that we're really only testing healthcare workers and inpatients. And they can donate at either 28 days after their symptoms have resolved or 14 days after their symptoms have resolved and they have a negative subsequent PCR. We're not testing patients widely, kind of retesting them to see if they have a negative PCR. So I imagine most of the patients who donate will be kind of within the 28 days period. And hopefully, they're hoping to get serology testing so that this huge pool of patients that we have that are outpatients who we presume have COVID could potentially be able to donate in the future once that serology testing is available. Potentially that huge pool of patients would then be able to go if they, if their serology is positive, then that plasma would be able to be donated and given to patients currently with the illness. So this is all kind of in process and changing and very quick, but hopefully we'll have kind of more of an update next week as far as exactly how we're able to get it and which patients will be getting it, and so more to come. And then an update on our testing. So we are still using multiple sites to test. So we're using Mayo, MDH, HCMC just released a test this past week, and then LabCorp. Turnaround time seems to be anywhere from 1 to 4 days, kind of depending on where it's going. And then we're still looking to get in-house testing by the end of April through Cepheid. One of the issues is that the hotspots are being prioritized at this point for testing. So and there are a lot of kind of shortages of reagents and swabs. So this is something that we are definitely looking towards, but things might change and things are still kind of moving, but we're hopeful potentially by the end of April we'll have in-house testing. And then as far as serology testing, LabCorp is making a product, is making a test, and it should be available by the end of April. Whether or not we would be able to get it at that point, once again, up in the air. I presume that they're going to, once again, prioritize places on the East Coast or in the South that are seeing more cases than we are. But some things to look at on the horizon. And then a couple of updates just for Allina specifically. So we created a COVID clinical content work group with two of our hospitalists, Dr. Sarah Preble and Dr. Love Patel, heading it. And really the goal of this group is basically to kind of address clinical questions that are coming up with COVID as more data is coming out and kind of being able to address these system-wide, staying on top of on data, maintaining order sets, streamlining care. And so currently, this past week, we were able to come up with 2 documents, one on guidance for auscultation with stethoscopes, and then one on proning and repositioning of non-vented patients. Those are available on the AKN. And next steps that we're looking at is working with pharmacy on clustering meds so that we're not going into having the nurses go into rooms so frequently, working on electrolyte protocols, potentially coming up with some sort of anticoagulation guide, as I'm sure people are hearing that there's a lot of reports of thrombosis within these patients, and then looking at kind of high flow nasal cannula and CPAP and when that is or is not appropriate. If anybody has any ideas or questions, feel free to contact us because we're looking to be useful to the whole system. And a couple more Allina updates. So all of our PUIs and COVID patients are currently being given cloth masks in their room that we're asking them to wear whenever us as staff are in there, nurses, etc. And we are also at Allina, a question that we're getting a lot of, which we are extubating some patients, which is amazing and great. And so we are seeing some patients that are recovering, but then, the issue is these patients need to either be in the hospital for ongoing recovery, or these patients might be candidates for rehab or, a nursing facility. And so the question is, how long do these patients need to be on isolation for? What is our strategy there? And so we are working with MDH on pursuing either a non-test-based strategy or a test-based strategy, and that it's still kind of, we're still having conversations, but the question would be whether or not patients, if they've been asymptomatic for a certain amount of time, if we could discontinue their isolation, or if there would be consideration for repeat testing, which, as everybody knows, testing is still, we still don't have the amount of tests that we were hoping to. So that is an ongoing conversation that we are having, and know that we are definitely talking about that. So more to come. So from my end, a couple of take-home points. So it seems that social distancing seems to be working in Minnesota. It looks like we're potentially flattening the curve as far as literature. So some things that we knew: older patients, that are majority of the critically ill, we knew that. Racial disparities do exist, it seems, in COVID-19. ICU stays are long. The reproductive number is potentially higher than we thought it was, and hydroxychloroquine and azithromycin probably ineffective. Remdesivir no longer available here except for compassionate use for pregnant patients and children. We did change some of our guidance as far as hydroxychloroquine, and keep an eye out for convalescent serum. We are working on that, and working on being able to get it here. And then if you have patients who are recovered, I would direct them to the Red Cross website. If they just Google Red Cross COVID-19, they should be able to find the website, and there's kind of a little form that patients can fill out to consider donating. And then we have established a COVID clinical content work group, working on kind of bigger questions, so more to come there. All right.
Thank you. Now we'll switch over to having Dr. Bradley present his slides.
Great, thanks for having me again. So I was first asked to give it a little bit of an update on forecasts for what COVID will look like in the state. The first comes from Governor Walz's presentation a couple days ago that suggests that we're doing a good job flattening the curve. But when it comes to understanding what happens next, the old quote that's been attributed to a number of people, I've seen Yogi Berra and Mark Twain, prediction is difficult, especially about the future. But we can take some encouragement from looking at our curves relative to other states, particularly Washington State, which preceded us by some significant amount of time, has a curve that is similar to ours, just slightly worse. In speaking with colleagues there and looking at reports there, it seems that they feel that they have started to come to the backside of the curve. The challenge as healthcare providers, as was noted earlier in the talk, is the length of care that's required for these patients, a third of whom are critically ill, is such that we continue to accumulate patients in the hospital despite the curve potentially tapering off. So although there are some encouraging signs, it does suggest we'll continue to be busy and at high census for potentially some time in the future. Also, in thinking about what the forecasts look like, there are some other encouraging signs as it relates to the IHME model. This is the Washington State model. Again, predominantly driven by looking at mortality. They've seen mortality in Italy mirror what they, to some degree, mirror what they predicted and starting to come down. The challenge is again, predicting the future is difficult. Their model would suggest for Washington State that things will improve by the end of May. Similarly, for Minnesota, they project our peak rate of death would be around April 23rd, with the curve coming down subsequent to that. But the models that are being proposed by the University of Minnesota, although they haven't revealed them specifically, suggest that the peak comes much later and that our degree of COVID activity remains much higher for a longer period of time. So I think that there are some things that we can feel encouraged about. The work of trying to mitigate spread by these stay-at-home orders have had some impact on what our curves look like, but exactly what that's going to mean in terms of when the peak is, what the overall burden of COVID is, all remains very unclear at this point. I'll move from there to speak again about clinical trajectories. This is something I've spoken about in the past. Just again to say that the goals are to try and help providers understand who are the patients who are at highest risk. These relate to demographics, presenting symptoms, comorbidities, and certain laboratory markers that we've been using to try and help providers differentiate patients who may otherwise appear to be at low risk, but may in actuality be at higher risk than otherwise anticipated. One of the factors that's been associated in prior studies is gender, and I haven't spoken about that previously, but looking at our own data, it's worth mentioning today. So now I'll speak a little bit about our local experience today. My data is not as updated as Dr. Lanassa's, so this is as of yesterday, 163 COVID positive. Of those, 63 have been hospitalized. We've seen 35 of those patients have been discharged since their hospitalization. Of those, none required ICU care. Of the patients who are discharged without discharge, so to date, their length of stay has been 3 days. Again, these are the lower acuity patients because we're not including any patients who have had ICU care. And the median time from symptom onset to admission was 8 days amongst these patients. Of the 18 patients who have required ICU care, 15 have required intubated. Of those, 6 have subsequently been extubated. And the median length of stay in the ICU for those patients has been 9 days, with a median length of mechanical ventilation being 8 days. The patient characteristics, just some very basic patient characteristics in terms of age and gender. You see the patients requiring ICU median age is slightly older, but the range is very broad, 25 to 79. So important not to utilize age only in terms of understanding risk. But interestingly, of patients who have required ICU, none have been male. They have, none have been female. They have all been male. So gender is associated with this. There are some hypotheses as it relates to the ACE marker that the virus connects to, and how that differs between men and women and why that might be. But we're seeing that also in our own population, that men are at higher risk of requiring ICU care. We're continuing to see that the markers can be helpful in preceding decompensation, but again, needs to be considered in the totality of the patient. And as we've discussed before, these are not diagnostic, but intended to be prognostic. Looking at updating our data from last week, again, we're finding ferritin tends to be the most sensitive and specific, with a sensitivity around 71% and a specificity around 29%. We've discussed this before, but again, the timing of that ferritin relative to symptom onset has importance. Later in the infection stage, beyond 10 days, almost everybody has a relatively elevated ferritin, even upwards of 600, but elevations earlier appear to be more significant. Utilizing both ferritin and CRP as pretty helpful in being sensitive, but not particularly specific. Nearly half of patients have an elevated ferritin or CRP above 600 or 10 on admission. So again, our tentative guidance has not changed. We're hopeful in the coming week to get more detailed data on demographics, understanding vital signs relative to their presentation. And concurrently, we're doing work with Lisa Kirkland, Allina Research, and the University of Minnesota, trying to develop predictive models. The challenge is any predictive model requires an adequate data set to build and train the model. And currently, there aren't enough COVID patients in our care system to develop those models. We're exploring developing a model in a flu population, where we could see if we can develop the model and then apply that to a COVID population to see how well it works, work that's ongoing. But right now, we're essentially using 1960s, 1970s approaches to looking at patients, identifying markers, and seeing how well we do and providing general guidance. I'll also ask to just briefly touch on COVID cardiac issues. Again, we're seeing more and more literature that suggests that COVID may have some trophism to the heart, so there may be issues related to COVID and direct cardiac injury. But it's important to recognize that oftentimes these studies are relatively broad in what they're describing as COVID-related cardiac injury. In particular, acute cardiac injury, which is usually defined as just an elevated troponin, is very nonspecific. It's found commonly, reported in up to 22% of hospitalized patients, but the pathophysiology is a broad range. So it includes typical acute coronary syndromes, demand ischemia, potential direct myocardial toxicity, so myocarditis related to the virus, stress cardiomyopathy, so like a Takotsubo's, and then myocardial depression, so patients who are septic or inflammatory can have reduced systolic function. The time course, it appears more likely associated with later illness or severe illness, and routine troponin still is not particularly helpful, but may be helpful in patients with more severe illness in assessing for other contributing factors. Myocardial depression, so again, this is a broad definition that includes myocarditis, stress cardiomyopathy, and the cytokine storm. The presentation, there are now case reports of patients who have presented with myocarditis as their sole symptom of COVID. So patients who present presumably several weeks after their infection, never had symptoms of COVID, but present with depressed systolic function, are tested for COVID, found positive, and then treated with subsequent resolution. This is similar to what has been described for other viral illnesses that can cause a viral cardiomyopathy and approached in the same way. Patients who have a stress myocarditis, so stress cardiomyopathy, or cardiomyocardial depression appears more commonly in severe illness, again, later on in the illness course. Arrhythmias have been described in patients with COVID. Unfortunately, not a lot of description in the type of arrhythmias. There obviously is the concern about QT prolongation that was mentioned earlier by Dr. Lanasa. It's felt that patients are particularly low risk if they have essentially normal QTs at baseline, and hydroxychloroquine has been used for a long time in management of other disease conditions and is generally felt to be low risk. We're currently working on developing guidelines as part of the clinical group that you heard about earlier to provide guidance and telemetry monitoring as we continue to expand that access. And then finally, venous thromboembolism. There's particular concern about this patient population. I'll refer you to the detailed guidance on the AKN that walks through. It's a fabulous document by Matt Lillibad. And then finally, I think it's important to remember that in the era of COVID, other disease conditions continue to exist. So there was a wonderful editorial by Harlan Krumholtz in the New York Times earlier this week, talking about how in the era of COVID, there have been descriptions of 30 to 40% fewer STEMI activations during this time, and there is concern that patients may be worried about presenting to the hospital and as a result are suffering from myocardial infarctions at home. Santiago Garcia has done an analysis of this exact question and has a paper that will be coming out later today in JACC that addresses this question. Unfortunately, it's embargoed, so I can't share with you the graph today, but perhaps someday in the future. And we discussed just last week a case where we were concerned about potential viral myocarditis, and it turns out that that patient's evaluation confirmed that he had an existing myocardial left ventricular dysfunction that was unrelated to his myocarditis. It just so happened that he had an event related to that existing disease condition. So important to think about COVID, but also important to think about what used to be horses for us can still be horses. With that, I'll end.
Great. Thank you both so much. We purposely wanted to leave a little bit more time this time for questions, so I will field a couple of them that that I can answer, and then we'll give it back to Dr. Lanasa and Dr. Bradley. But one that came up about the sterilization of masks at Allina, and so we are waiting for 3M to kind of validate the sterilization procedures that have been publicized throughout the US, specifically the UV one. The hydrogen peroxide, vaporized hydrogen peroxide, that's also being looked at, but the supply is very limited for the actual hydrogen peroxide itself. So I don't have a time frame as to when or if we will be doing sterilization, but it is being looked at a system level. Another question was about the donated cloth masks for the patients, and is there like a standard that we are holding people to? The answer is Allina put out some guidance to that, but they are accepting all comers, and yes, they are being washed before being given to inpatients, but then they are not being reused amongst inpatients. So the mask goes home with the patient and is not reused for subsequent patients in the hospital. And then one more about CPAP and whether or not they should continue to use CPAP as an inpatient. I think it's a great question because, as we know, CPAP and BiPAP are aerosol generating, and so I think more to come on that, but for right now, we are still saying that probably for routine OSA that we should forego the use of CPAP or BiPAP in our COVID patients. We also addressed that a little bit in the awake proning protocol because, as you can imagine, if you're not lying flat on your back, but potentially prone or just on left or right lateral decubitus positioning, you could help maybe prevent some of that obstructive sleep apnea from occurring. And then if there is capnography available, that would be kind of a nice surrogate if you're not allowing routine CPAP use. All right, so I'm gonna ask some more questions to our experts here. One about, does the lack of testing in Minnesota affect our predictive modeling here, especially if we're mostly testing healthcare workers and inpatients?
Yeah, that's an excellent question. Essentially, because of the lack of testing, you have to do some sort of back calculation to try and figure this out. And so the way you do that is you choose an endpoint and then try and understand how that correlates with the degree of infections, and then based on our understanding of the epidemiology that was shared by Dr. Manassa, what that means for the future. So the model from IHME essentially uses mortality, suggesting that mortality is the most definitive endpoint. I think that may be true in systems that are not overwhelmed by COVID, but then it becomes challenging in places like New York, where deaths may occur at home and then are not reported as COVID, as has been suggested in the literature, or in Italy. But if you have an understanding of what the mortality rate is, that gives you an understanding of what the anticipated COVID disease prevalence is in the state, even without adequate testing. Similarly, you can use hospitalization, so that's what some other models use. So you can make estimates, but again, the problem with prediction is it's about the future and it's dependent on the inputs and the assumptions, and all of the models are a little bit different.
Great. There's a lot of questions about the antibody testing and when that will be available and who we think that will be using that in at first.
I mean, that's a great question. You know, we're hoping, once again, LabCorp should have a test available at the end of April. The question is whether or not we're going to get it, or if they're going to divert most of their tests out to hotspots. And I think it's still to be determined as far as who we are going to test with the serology testing. I think that's something that we definitely need to address, and I think kind of it'll be dependent on what our testing capability is and kind of what the future is looking like. So still to be determined.
Right. One question that was, they said, kind of left over from last week, but a good question that I want to touch on is how do we get outpatient oxygen to people that may not actually need hospitalization but are newly hypoxic? So I'm on a work group along with Emily Downing that are working on what our home health care spectrum can look like. So there's kind of three buckets. There's the traditional home health plus, and home health max, which you could kind of think of as more of a hospital at home model. And so we're actively trying to figure out who fits into what buckets based on objective data and criteria, and then also what that follow-up looks like and what things they need at home. We've looked at, like Cornell has been doing this where they use an exertional O2 saturation, and then based on that, they give people oxygen concentrator and a pulse ox at home, and then do frequent virtual visits for the next couple of days to look at trajectory. So something along those lines we are hoping to roll out in the next couple of weeks, hopefully sooner, so that we can get some of these patients, once our census does start to increase, keep them out of the hospital, but still keep a close eye on them. One question about where can outpatients get tested in Minnesota? And
I don't know if Mayo might be testing some of their outpatients, but I'm not quite sure. I don't think anywhere in the Twin Cities.
I'm not aware of any here. Allina right now does not have the testing capability to do that.
Okay, so just to, in case you couldn't hear, maybe Mayo, but for sure in the Twin Cities area, we are not aware of any outpatient testing, and except for those kind of special groups, the healthcare workers or people going to in congregated living situations. A question about a lot of news coming out about a BCG vaccine. Any thoughts?
I don't know.
Unclear at this point. We'll address that if there's more data that comes out about that. Dr. Bradley, one about when can we anticipate a second wave of COVID cases?
I think we have to first understand when we're through the first, and then after we're through the first, everybody who's doing this modeling will learn a lot about what the impact of mitigation was on the shape of the curve, and then that would presumably inform what mitigation strategy is going forward. But I think it's nobody knows anything in actuality about what this is going to look like in terms of seasonal change, what this looks like if restrictions and mobility are removed. All these things are such unknowns that I think they contribute to what is an appropriate conservative strategy for now.
A lot of questions again on the thrombophilia piece for COVID patients, and so Dr. Bradley referenced a document. I actually don't think it's on the AKN yet, so okay, so we will make sure that it's on the provider resources page on the AKN so that it's easily accessible, and then also our clinical content group hopes to provide some kind of guidelines for when we should be doing these things and get them into order sets if appropriate. The next question was for virtual visits or telephone visits. If we don't have the luxury of an O2 sat monitor, what are the thoughts on the Roth test for virtual assessment of oxygenation status for these patients?
I'd have to defer to my pulmonary and respiratory colleagues.
Okay, so the Roth test is something, I think it came out of Israel, and so it's counting to 30 in your native language and seeing how quickly you can do that, and then also if you have to take any breaks. And so we can look a little bit more into that and see if there's any data about that and then bring that back next week. Question about convalescent plasma, transfusion reactions and risks associated with convalescent plasma.
I mean, I think, you know, the same risks that can occur with plasma transfusion or blood product transfusion is there. I mean, there's still, we don't have great data for convalescent serum therapy. I think it would probably be kind of a potential Hail Mary therapy for these patients. I haven't heard of any bad outcomes at this point. I know, you know, there are some thoughts as far as, you know, could it be harmful? You know, could there be some degree of, you know, antibody dependent, you know, exacerbation? But I think that's all very theoretical at this point, and so I think that, I think it's a reasonable therapy, and, you know, a lot of issues that might come with it will be declared.
And I think that's one reason why it's so important to do things like this in the context of a study, if at all possible, so that we gain the critical information that we need to have in order to know how effective a treatment like this is, because it does have risks.
And there's a question about for the convalescent plasma donation, are they only taking males or never pregnant females?
I don't.
We had a discussion with somebody from the blood bank who's on a national panel. They are taking both, but they have to do additional testing on females who have previously been pregnant. But they aren't taking anybody.
They are taking all comers.
That's what I think.
Yeah, that have had COVID.
Yes.
One question about steroid use, and is it safe in recovering COVID patients, like for example, to treat autoimmune hemolysis?
I haven't, so I've seen a lot of mixed data on steroids, but kind of the bottom line seems to be that if a patient has COVID, but then has a separate reason why they need steroids, that you should give them steroids.
One question about outpatient providers, seeing patients in respiratory clinics, should they be wearing N95 masks, or are these preserved mainly for the ED hospital? And what about cappers in that setting?
The PPE strategy for the respiratory clinics is under active discussion. We're still trying to get a clear and confident understanding of what our supply is. So stay tuned for that. It's a very good question. That hasn't been finalized yet.
Another question on PPE, talking about N95 versus surgical masks for healthcare workers. We've heard that some other healthcare systems in Minnesota have switched to N95s.
Repeat the question.
The question was, some other healthcare systems in Minnesota have switched to healthcare workers all wearing N95s as opposed to a combination of droplet and N95s.
It is not as clear as that may seem. I don't personally have direct, but from what I understand, what we are doing at Allina is very similar to mHealth and Hennepin County and so forth. But again, that is another thing that's under active discussion. We're trying to make sure that we protect our providers, but we also have to work in the context of the PPE supply we have and looking as best as one can into the future, what the models tell us what to prepare for. So that's an ever-changing prospect.
There's another one for a clinic patient. Please comment on when or if to use nebulizers on a PUI in a clinic setting. I think that one's tricky because if it were in the hospital, we would say to put them in airborne precautions, ideally in a negative pressure room. And so I think that without the appropriate PPE, it would likely not be recommended that you do nebs in if you don't have enhanced airborne precautions. The PPE to support that. Question about how soon to restart elective procedures. Is PPE the limiting factor?
It's one, but not the only factor. And I know that that's been under intense discussion when and how to prioritize where the procedures have to be done, staffing and many factors, but there is a group that's working on that quite actively.
Another one on PPE, are they to be reused until soiled, or are they to be used once, for example, for one procedure? And should we put a standard mask over them to protect them from being soiled? So I think the answer is no, we don't want you double masking. The ideal would be that whatever mask you have on, if you are going to be in a COVID positive PUI or unscreened patient, that a face shield should be used because they're far more able to be disinfected rather than double masking. And as far as the procedure, one-time use for a procedure, I have not seen that anywhere. I think the idea is to reuse until it does not pass your fit test on your face or it's soiled or hard to breathe through, making sure that we use face shields in all of those previously said situations. Question about, with almost 500,000 cases in the US, is there national data breaking down hospitalization rates, ICU rates, and mortality rates based on age by decade to better help us understand the severity of the disease based on age and which age groups are relatively low risk versus high risk?
So I can speak about the anticipated, what we can anticipate. So there are a number of registries that are being stood up right now. One is through what's called PCORNet. So this is a national collaborative that leverages existing data to understand care. Allina participates in PCORNet through the Greater Plains Collaborative. Raj leads that work, will be very helpful in understanding those aspects. There are a lot of additional registries that are interested in specific questions. As a cardiologist, I can speak to a registry that's being stood up by the American Heart Association, which I'm a member of the steering committee, and Allina Health anticipates participating in. I've been impressed by the state data. It's if you haven't gone to the Minnesota State dashboard, it's quite impressive. It speaks to the collaboration between the health systems and understanding what's happening in our state. I don't think that's happening quite yet at the national level, but certainly there is ongoing work to try and provide that information as rapidly as possible.
Can you comment on the possible reinfection reported by South Korea?
Yeah, so I had heard about that, and I think at this point there is some suspicion that it represented recrudescence rather than reinfection. I think the future will tell as we have more patients who have recovered and seeing what happens. But at this point, I'm suspicious that it wasn't reinfection per se.
Okay. Just gonna get a couple more of the newer questions that have come in. Give me 1 second. I've heard about some outside labs that do serum testing for $100. Any thoughts on those tests? I think that'll probably be a popular question that comes up for our outpatient providers.
Outpatient tests?
Yep, the outside labs, not through Allina.
Yeah, I can't comment specifically. I do know that Dr. Anthony and the lab folks look at critically all the tests that they have available, and there is a word of caution about certain labs because not all labs engender the same degree of confidence in the integrity of their tests. But I would defer that's something that Dr. Anthony and her group looks at very carefully. I can't comment specifically on the one you're referencing, but just a word of caution on those.
Question about, do we have a sense of the number of patients who die that expire from a cytokine storm, and are we measuring IL-6 levels? I think it's also asking, has anyone at Abbott been treated with acetromab?
Oh, that's tocilizumab. So we're not able to measure IL-6 levels because it's a send out, and I think it takes like a week. And so I think we're using CRP and ferritin as a surrogate. I believe that potentially IL-6 drives CRP or the reverse, but we have used tocilizumab on, I know I've used it on one patient. And the theory, basically, it's an IL-6 inhibitor. And so the theory is that potentially you could halt that cytokine storm from causing ongoing tissue damage. There are studies that are going on looking at this specifically. And I think, I'm not quite sure as far as the data, as far as what percentage of patients that die, it's a result of cytokine storm as opposed to something else from the infection. I would presume a lot of the deaths are probably secondary to that. But I think these IL-6 inhibitors and immunomodulators, I think it's intriguing as a treatment, and hopefully we'll have some preliminary data coming out of the United States as far as kind of what their efficacy might be, but it's still very early.
Okay.
Oh, and I'll just mention the patient that I treated with tocilizumab. I'm not quite sure if it did much, honestly. Yeah.
Lots of questions. Just reading through them about N95s. CDC says to have 5 masks and rotate through them. And then what do we do if the straps on the mask become loose? Is there a way to reattach them instead of throwing the mask away itself if it isn't soiled?
Yeah, the 5-day strategy, 1-5-2, use one mask one day. On a 5-day rotation, use only one mask for, use any one mask only for 2 times. There is a 1-5-5 strategy. There really aren't solid data to guide that. The best data I've seen that after 5 days, there isn't much virus found on the outside of a mask. that has been laid down, but I don't know of any data beyond that, or any data to say after 2 days how much is contagious. And again, this has to be considered in the context of the total supply of N95 masks and what would our supply be like if we gave every person a mask every 5 days, or 5 masks every 10 days. If a strap breaks, we're encouraging people to turn that in, because depending on how it's repaired, what we do not want to happen is somebody to put on a repaired mask, be in a room with enhanced precautions, and have that mask fail. So I think if it breaks, you don't throw it away, but turn it in, and if we devise a way to reliably fix it, we can do that, but it's preferable to get a mask that you know is going to work.
Good. One question about, is there any utility in doing the blood work? I think they're referring to the 4 prognostic labs in the respiratory clinics and then repeating them in 72 hours.
So all of the data thus far has been in patients who have been hospitalized, and so we don't have guidance to suggest it has utility in the outpatient setting.
And then another question about Alina's staffing. If we do get into a situation where 30% of our workforce or 40% of our workforce are on quarantine or out sick or can't come to work, it can not give specifics about that because I'm not directly involved with that working, but yes, they're looking on all sorts of workforce reutilization plans, both for nursing and for providers, including having, looking at clinic docs coming into hospital settings, looking at anesthesia, providing more critical care training or critical care coverage. So yes, the work is being done. I can't give a lot of more specifics than that. We'll do one more question. I guess this one, there's a lot of information coming out here. What are these doctors in the room's biggest takeaways from this session? Or I guess maybe just biggest takeaway in general regarding COVID?
I guess, it's a very serious disease, and I think there's a lot of data that's coming out. A lot of it, I think a lot of it we might need to take with a grain of salt, because I think a lot of the data that's coming out isn't necessarily peer reviewed. I think things are going to be changing a lot, so I think we all have to be very flexible and open to having something be true one week and then the next week something else being true. And so I think, us as providers being flexible is something that's really important. Something that's encouraging that I'm seeing is, I think for a large percentage of these patients, supportive care is the best treatment. And so I think we hear about all these treatments, politically or on Twitter, and I think at the end of the day, our eyes need to stay on the prize, and I think the prize is excellent critical care, good public health practices, and I think eventually vaccine R&D. But I do think that with excellent critical care, we can potentially get a lot of these patients through their illness, and that's something that's been encouraging to me, but it is definitely, very significant, causes significant and severe disease. So.
Great, I'll let Dr. Bradley give any of his 2 cents at the end here.
I don't have a whole lot to add to that. I think that because of the last time we had a pandemic that was before any of us was born, and so this is something that none of us is used to. But I think that we have to. We were trained as clinicians, and we apply those tools to manage our patients. And sometimes we may not know the answer, but we rely on that training to provide the best care that we can, and we supplement that with continuing knowledge. And I think this has been an excellent forum to continue to add to that knowledge with the understanding that our appreciation and understanding is going to change over time. The cardiologists, we've been involved in trying to provide some of that clinical guidance, so we've specifically avoided the word guidelines, because to that point, this is about guidance and trying to do the best they can, both with their training and tools and some general concepts and thoughts.
with that, we will close for this week. Next week, our goal is to do have Dr. Lanasa do a portion of it, and then have a intensivist do some critical care specific education and talking about not just ventilator and ICU care, but also high flow nasal cannula and CPAP. So that's what you can look forward to next week. Thank you all for attending, and stay safe. Bye.